Could everybody take their seats, please? We're swapping round the last session, and we're going to invite Amani up first, who's project manager at the NPDA, to talk us through what next.
My slides to come up. Nope. There you go. Hi everyone, I'm Amani Krayem. I'm the project manager of the NPDA. For those of you who have not met, I've been in this role since June, so many of you will have remembered Holly Robinson, who's in the role before me. I just wanted to give an update on what we've been up to in the past year, so since I started and a few months before, and our plans for the next year and the period onwards. So, since our last conference, this time last year, we had a webinar on NPDA reporting. So that looked at the process of data validation, cleaning, analysis, quality assurance, and reporting. And we also gave a sneak peek of our quarterly reporting dashboard, which was published later in the year. We then published our 22-23 report on care and outcomes and the associated outputs, so the extended analysis, data files, unit-level reports. We then shared data with NHS England. So you would have heard earlier today about the 5-year hybrid closed-loop implementation strategy. So in line with that, we've been sharing data with NHS England to monitor the rollout of hybrid closed loops so that we can monitor the number of children on a hybrid closed loop at each ICB, and reimbursement can be given to those ICBs. And that data is also being used to inform the GIRFT visits at each ICB. That includes 23-24 data, so that full year, and then we've been providing quarterly data since the start of 24-25. We then launched a frequent reporting dashboard, which you've seen a few screenshots of today, and you can see again at the bottom of the screen. So this was first published in July. There was a little bit of the delay due to the general election, but then it was published with a full year of 23-24 data, and it's been updated quarterly since, and the next quarterly update will be out in the middle of February. These are now accompanied by data files, so anyone who's a bit Excel savvy can make your own visualizations as well, allowing you to compare between, say, different PDUs in your network. We've had a lot of really great feedback on the dashboard, and I'm really pleased to see how widely it's being used already. But we're also happy to take any feedback on any improvements. When we have time, we would be more than happy to improve the dashboard. It's never final. Since then, we then onboarded Jersey into the audit. So Jersey joined the audit year of 2024-25. You can already see them on the dashboard. And you'll see their data in future outputs, starting with the 2024-25 annual report. We then presented at ISPAD in Lisbon. So we had an oral presentation on the findings of the PREM, and that was specifically on the impact of a diabetes diagnosis on parents' employment and their sleep. And we also had a poster on the change in pediatric diabetes incidence and the seasonal patterns of diagnosis in the years following the COVID-19 pandemic. We then published a PREM report. This was our first PREM to focus on the first year of care after diagnosis. That has been published a lot, and soon there'll be an extended analysis of the data, as well as unit-level reports where there are more than 10 responses, so that we don't identify anyone in those reports. We've since submitted our 23-24 annual report for feedback, and we've prepared the unit-level summaries. So that data the unit-level summary should be available to units fairly soon, hopefully in February, and the report published in March. And we've submitted our type 2 diabetes spotlight audit as well. So that data was collected in the summer last year after a few delays, and we're really pleased to see really great participation in the spotlight audit, considering the reduced data collection period. And this has allowed us to look further into the care and outcomes of children and young people with type 2 diabetes in the year 2023-24. Last year, we were also securing an extension into 2027 onwards. So our current audit contract finishes in April with our funders, and we've now extended that until April 2027. And I'll touch a bit more on what our plans are for the next 2 years in a bit. And lastly, we facilitated quite a number of data access requests and extended outputs of the audit. So this includes the international collaboration of diabetes registries that Justin mentioned earlier. We've been working with Dr. Renuga Diaz at the University of Birmingham to look at the relationship between ethnicity, deprivation, HbA1c outcomes, and to replicate research from 10 years prior. And we're also in the early stages of a data access request with Digital Health and Care Wales and data for 2 journal articles. And during this time, we've also had quite a few staffing changes whilst managing all of this. So you'll know that I am new to the project, taking over from Holly Robinson. Natasha Long, the previous project coordinator, left for a new role, and so did Killian Brophy, the previous data analyst. We now have Richard Shepherd as our new project coordinator. If you've been in touch on the NPDA inbox, you have seen emails from him. And Nam Fang joined the audit last week as our new data analyst. So what's coming next? So we've already started to think about retendering up for 2027 onwards. And we're starting to think about what we want the NPDA to look like in that time, how the NPDA might have to adapt, and how we might change how we collect data in that time as a result of the changing needs. We'll also be publishing the 23-24 reports, so in March for the annual report and in April for the Spotlight report. And then extended analyses and unit level reports will follow. We've also planned to launch a new NPDA data capture system. So those of you who enter data into the NPDA know we've been using the same data capture system for a while, where you can enter data via questionnaire or via a CSV upload. So we're bringing a new data capture system in. You'll still have the same ways of entering data, but what will change is the accessibility of that platform, how you use it to enter data, how easy it is, and the feedback that you get back. So the reporting that you get in real time based on the data that you submit. One example is this map on the screen. So you'll see this is just an example of London. You'll have a map of the area around your unit with the deprivation rank of that unit. And if you had patients, in this example I didn't, they would be mapped on that map. So you could see for each individual patient what quintile of deprivation they live in and how far they are from your unit as well. And we hope that this provides you with a little bit more real-time data, not necessarily for reviewing your data quality, but for quality improvement purposes, and to be able to see the specific needs of your patients at that time. We have also commissioned DigiBeat to produce films based on the findings of the Association for Young People's Health report into the experiences of children and young people from marginalised communities. And they'll also be producing a film based on the poverty proofing report. So they'll be producing resources for children, young people, for families, and for healthcare professionals based on those. We've also commissioned Children's North East to offer poverty proofing training that we've heard about earlier to all paediatric diabetes units in England, Wales, and Jersey. And we'll also be doing some PPI or engagement to gather children and young person and parent and care perspectives on the use of their confidential data for the NPDA. So the NPDA does not collect consent in collecting people's data. We have an exemption for that. But we do have to evidence that this is in the public interest, and to meet our duties and the rights of the child, to give them the best access to information and best healthcare, we felt it would be best to do some engagement to see what kind of information, again, children and people want to know about how their data is being used, and whether the current model is appropriate depending on what families and children and people feel. We'll also be updating the NPDA data set this year for launch in 2026-27, so April next year. So we'll be reviewing our data set as we do every so often to check that it is still relevant, still up to date, still in line with NICE guidance, and still useful, that we're not hitting a ceiling of some of our data, and we need to ensure that we're answering the questions that people have. And we'll be rebuilding NPDA results online as well. So that was our annual sort of dashboard that we updated with the validated data each year, so we'll be thinking about an alternative to that. And then lastly, we'll do some reporting for the 2024-25 as it's ongoing, and start data collection for 2025-26 from May onwards. That will be all done on the new platform, the 2025-26 data. If you're interested in testing the platform before it launches for 2025-26, please do send an email to us. It's npda@rcpch.ac.uk. We would like to have some people try out the platform, try entering data before it rolls out to everyone to make sure that it at least does what the previous platform did and hopefully a bit more. I'll just touch on what we're doing in the next 2 years, so our extension into 2027. So on top of our core annual report, we'll be doing 2 additional reports. One is a workforce spotlight audit. So you may remember we did a workforce spotlight audit in 2017 to 18. This is a repeat of that. It aims to identify the numbers of patients with additional care needs at PDU levels, the current staffing levels and whether this aligns with guidance from the network that was published recently, and especially how this has changed in line with the increase in prevalence since the last spotlight audit. And to also look at psychology and transition standards within units. In the next 2 years, we'll also be doing a PREM. The topic is to be decided on the PREM. I haven't got dates for you at the moment, but as soon as information is available, that will be shared with Pediatric Diabetes Unit and with the networks to make sure that they are prepared for this additional data collection. And I've just put a little nice quote there from our commissioners from our approval letter for the 2-year extension. I just want to say thank you. So thanks to everyone who's been submitting data into the NPDA, but also who's been using the results to improve care. We've seen so much of that today. I think NPDA data was part of pretty much every presentation, and that is really great. I'm really pleased to see how it's being used and the impact of it. Just want to say thanks to the NPDA project team and the wider audit team at the SPCH, some of who are here today running around with microphones. The project board and the data set and methodology group, the CIP Diabetes Network, HQIP, our commissioners, and the families of diabetes and children and young people whose data we use to fuel the NPDA. So thanks.
Thank you very much, Armani. You've addressed some of the questions that people often ask about what next and what else can we include in the data set, what else can we look at that would be useful for quality improvement. So all those things are on the list. We could have one question and then I'd like to move on. If there is one question, we've got time for one.
Thanks, Amani. It was very good. Have you thought about, obviously some of us in this room have been involved in Q, and we've been working with a completely different database, which is obviously GP-led. It's called Eclipse. And I'm just interested, having worked with that, I'm sort of interested. I wonder whether that might be the way the NPDA starts to go, that, all this data goes in together.
As in to use data from these Q databases as well?
Well, exactly. Q to interface with NPDA as well, since diabetes is a very common complication.
So it's something we're thinking about, is how we can amend the NPDA data collection processes to use data that's readily available, so we're not duplicating work. And that's something we're thinking about, especially in the period post-2027, which I know is a long way away. We're also changing the questions, and so it will very much depend on what data we are collecting and whether we collect data about Q. That, again, we have to align with the NICE guidance. So it will depend on what the NICE guidance is at the time that we're collecting that data. But yes, we are very much thinking about other sources of data that will reduce the data burden on units.
Thanks.
Thank you. Thank you very much, Armani. So last but not least, we have Diana Yardley, Advanced Nurse Practitioner from Oxfordshire Children's Diabetes Team. Welcome.
Thank you. Thank you, Amani, for switching places last minute. I appreciate it. Some slight tech issues. So my name's Diana. I'm a diabetes nurse from the children's team at Oxfordshire, and I'm also a PhD student at Oxford Brookes University. And I want to talk to you today about psychosocial barriers in diabetes care. So we're going to change tack a little bit, and there is some audience participation. So, okay, so we've heard a lot about this. This is going to be a lot quicker than I planned, one of the benefits of going last. We've heard about, this is an old slide now, how things have improved over the last few years and all of the different interventions that have been put into place in terms of things that have contributed to that, including this big focus on closed-loop therapy and real-time CGMs. We've also heard today about the poverty briefing and all of those things that have made a difference to families when we think about those considerations as well. However, we've also heard that despite these interventions, our HbA1c levels are generally similar than they have been the last couple of years. And still a large proportion of our families aren't managing to achieve those recommended outcomes that we are looking for. So perhaps we need to think about other things that interrupt families' ability to manage diabetes. So I'm going to take you slightly down the safeguarding portal because that is sort of the area that I've been looking at in my PhD, and I'm going to share some of that information with you shortly. We heard again this morning that the incidence of diabetes is increasing within children in the UK, both for type 1 and type 2. We heard that the incidence is probably stabilising in comparison to how it has been, but we also know that a large proportion of our children and families still have a HbA1c that's above target range. If we think about children's services, so children's social care and the other services that fit within that rather large umbrella, there are suggestions that they receive within to children's services nationally in excess of 640,000 new referrals every year. 400,000 of those end up going onto child and need plans, 50,000 further end up in child protection plans, and there is a huge, I can't even do the maths and think and talk at the same time. Their incidence versus ours is significantly larger. How can they meet the need that we're asking for additional support with? But also, this is very often the means that we need to access for support. Kaya asked a question earlier on about thinking about children in care, and I have got a slide. The next slide talks about the previous workforce audit, but this is a staggering statistic that the NSPCC have suggested that the looked after children rate is rising quicker than the UK population of children in the UK. And there's a huge remit here in terms of looking after children at sort of team around the child level, right up to looked after children. Obviously, there's a huge spectrum, but actually, that's a very sobering statistic for some of the children that we care for. As Amani's just mentioned, and we mentioned earlier on today, there was a workforce audit done in 2019, and within that, they reported that 3.7% of paediatric diabetes units had caseloads that included children on child protection, child in need plans, and also children who were looked after. Another sad statistic is that actually child protection plans are twice as likely within children with diabetes, and also highlighted that for teams managing diabetes, there was a reticence for us to think about acting much earlier. As I've mentioned already, this is a huge umbrella, and actually what that workforce audit didn't consider was those 200,000 children that the Children's Services reports, for example, the Department for Education, etc., had reported that didn't meet threshold for child in need or child protection planning, or indeed children who've sadly lost their lives due to diabetes neglect. I am pleased to hear that there is a repeat audit planned, and stand with Kia in many ways when suggesting that perhaps we need to look at actually how much of this is happening. I've already mentioned and tipped the hat to a lot of these initiatives that are already in place, and we've heard from Jenny today. We've also, Sanjay stood up and mentioned the study that he'd been doing up north as well. There's also many more pockets of activity that I didn't know about before today or didn't know to mention, but there's also this really comprehensive guide that the NHS England South East Tech team have put together in terms of accessing some of those additional pressures that exist within families. Ultimately, I think as diabetes teams, we need to think differently about the way that we support these families in our clinics. We've paid great attention to deprivation recently. Previously, we've paid increased attention to psychological need, and we're recognising that those are difficult things for our families to deal with. But what about where there are barriers to managing the diabetes that aren't actually about the diabetes? So access to technology, amazing, brilliant. Improving access to clinics, improving the ability for those families to access additional support for funding, for provision in terms of reducing poverty, etc. But how do we meet some of those needs or some of those measures that are social? Can we do that with medical measures? And I'd suggest to you that perhaps we can't. You may have seen it in one of the previous slides, the mention of the social determinants of health. This was something that's been bouncing around for a while, and this reference is from the World Health Organization in 2010. So these are things that are non-medical factors that influence individual people's health outcomes. The conditions in which people are born, grow, live, work, and age. And they're affected by a wider set of forces. These forces and systems, for example, include the economic policies that we might have discussed earlier today, systems that exist around those policies, development agendas, social norms, social policies, and some of those political systems that we're all influenced by. I'm not going to read that list to you, you can do that. Once again, I want us to think about, or I'd like us to think about, how can we account for some of these things if actually we don't understand those within our day-to-day practice? And also, to some degree, is it our role as health professionals to do that? Very often as healthcare professionals for diabetes children, we might be one of the only teams that are involved with that family, particularly if they've decided not to engage in school education anymore. Or we might be that consistent where those families are coming regularly on that 3-month basis, as we heard earlier about that burden of care. We are seeing those children very regularly and puts us in an ideal place to potentially pick up on some of those concerns. You may or may not be familiar with Bronfenbenner's ecological framework. This was developed by a psychologist in the 60s. He sort of goes alongside with the social determinants of health to think about the fact that that child is influenced by many things, not just in the home, the people immediately around them, but also those people in the slighter, wider scheme. So families, immediate families, but those school teachers, peers, etc., groups in and around those families, and the relationships that exist between those people and between the betweens, so around the bigger circles. Outside of those circles are the wider social pictures, if you like, so the education policies, the social care policies, all of those sorts of things, government agencies, mass media, etc. And so it gets bigger, but they all influence the child. As diabetes professionals, we exist here, but I'd say we exist across all of those spheres as well. This is a quote from one of the participants in my study, and it captures a lot of this for me, that actually when we are looking at doing those safeguarding referrals for our children, very often diabetes isn't the fundamental problem. However, it is the problem that makes many of these children visible to us. So I'm going to share a little bit of information about my study. So I've been exploring paediatric diabetes healthcare professionals' experiences of specifically child protection and safeguarding. I had started off looking about type 1, but people wanted to tell me about some of their experiences with type 2 as well. I recruited 20 participants across the England and Wales through the National Diabetes... Oh, hello. Hello, go back. Did I do that or did you do that? Across England and Wales, through the national network. I completed semi-structured interviews online, and you can see the breakdown of my participant group. Unfortunately, I didn't manage to recruit any of the social workers or family support workers working within children's diabetes services. I want to share some of the information that they've shared with me around vulnerabilities and psychosocial issues in their diabetes services, but I wonder if we might be able to do a little bit of participation here. So I'm curious, in your individual teams, are you routinely screening for vulnerabilities in your families? If you could scan and join in, that would be amazing. Thank you. Give that a couple of minutes to kick in. So that's quite interesting. So 91% of people, it's changing a little bit. Okay. So the majority of people are saying no and 15% are saying yes. I'm really hoping, whether the next question comes up, I don't know if it has for you guys. Can you see the next question on your screen? Does it ask you about which ones you use? Oh, let's see what happens if I press that. It doesn't. That's annoying. Are you able to take over control? See the second. Yeah, I did that. It goes on to the next screen, though. Oh, there we go. Okay, so this is a break. So thank you, everybody that's participated. So the these are the answers that people who are then submitting those, doing those vulnerability tools, what tools they're using. So a lot of the majority of people are doing an in-depth social history. Some are doing a general social history. I think that's quite common in most services. A very small proportion doing a strengths and needs assessment, which is a social care tool, and then 12% doing others. I'd be interested to hear what that is. Please do send me that information if you've got it. Thank you for those that are still contributing. I thought I'd share with you some of the vulnerabilities that my participants have observed in the families that they worked with, she says. She's got stuck. Can you see that back there? So I've tried to put this almost in that Bronfenbrenner kind of onion design again. So we've got the child here in the middle. Some of those things that directly affect that child. So other untreated conditions, whether that child's got learning disabilities, communication difficulties, for example, other past medical histories, the age of the child obviously makes a difference. And we've talked about poverty and deprivation. But these are some of the things that are affecting the wider picture for those families. So some of those other things that their families are presenting with or professionals are observing in and around those families. And they range from the cohesion within that family system, who's in the family system, what the parenting style is, whether they're particularly authoritarian or particularly laissez-faire or somewhere in the middle. I'm going to share something with you that I hope to be able to move forward with post-study that I might be able to help us in these discussions, that might be able to inform us in these discussions where we're in clinic and we're able to think about with a family, if we're thinking about a range of vulnerable to not quite so vulnerable, where does this family sit on that? So this is kind of based on, for those of you that are familiar with it, the graded care profile, which is a social care tool that they use to help them to, grade isn't really a term that I want to use, but they help them to identify where that spectrum of need exists for that family. So they use a scoring matrix to be able to say, actually, there are no concerns about this family, there are some concerns about this family, or there are significant concerns about this family. And they would then put in a short-term piece of work and then be able to demonstrate that this was effective and not effective and then potentially escalate it. And I suppose my ultimate dream would be that we can have something that we might be able to use in our services to do that as well. So thinking about, actually, I'm seeing this family, they're engaged, they come to clinic, they do very well, the child and the family have a good relationship, they work together well. I have no concerns about this family at all. Or actually, sometimes there are some things that pop up. I might not be worried about seeing the data, they engage beautifully, they come to clinic, but actually there are some other things coming up. For example, perhaps those lows aren't being treated, or they're dealing with ketones in the community of over 3 on a regular basis and nobody seems to think that that's a problem. Or really significant things, those repeated DKAs. And I forgot to take that out or decide what I was going to do about it, but this is still a working document. Those significant hypos that resolve when they're in hospital, even though parents have asked teams have asked the parents to observe insulin administration at home. So just a little glimpse of something that I hope to be able to drive forward in the future. So just thinking about concluding slowly, a call from me, from the participants that I've been so overwhelmed by their contributions to think about how we can better understand the level of needs within our families, to better understand how many of our families actually require additional support and what kind of support they're needing things with over and above that deprivation or that poverty or that ethnicity potentially. What other vulnerabilities are causing blocks to those families being able to manage the diabetes? I do think we need to understand better how we are dealing with this within diabetes teams. As diabetes healthcare teams, we are often dealing with social elements. Somebody mentioned earlier the talk about the family support worker. By having people like family support workers, social workers within diabetes teams should free us up to do a lot of these things that we've been talking about today to improve the care for children with diabetes, because that's pretty much what we're here for and why we're commissioned. But we can't do it because we're chasing a lot of those other things. We need to think about in teams how we can discuss positively with families earlier. These things seem to be difficult for you in clinic, or in life. How can we access support for you? Being able to develop our staff to have those difficult conversations earlier may mean that we can start to implement those support or access those services that are available. But to do that, we need to be able to understand what is available in our areas. So I think we need to have a better understanding of that as well. Thank you very much for listening. If you have anything you want to share with me, these are my contact details. And shameless plug, young Ben over there is going to pop the other QR code up for me. I'm with Care and a couple of other people looking at the access to social care in the A1 strategy. And if you haven't already, please contribute to this slide so that we can think about collectively how we might be able to drive that forward. Thank you very much.
Thank you very much, Diana. I'm really pleased that this work is being taken on, because there are so many of us who would benefit from tools and a structure and consistency at identifying children with vulnerabilities early on. Are there any questions for Diana?
Silence.
I'd like to ask a quick question.
Okay.
So you gave us a question about, do you routinely use vulnerability scores? I'd like to ask how you use them in your practice, and whether you use them universally with everybody, at what stage after knowing a family, or do you...
That's a really good question, thank you. Currently we don't, but funny you should mention that. It's something that we have bounded around, and one of the reasons that I ended up doing my PhD is I could see this as actually, are we, when are we, why are we not? When should we? And I'd had this idea about developing some kind of tool that would give us those strategies a long, long time ago. I think, like was mentioned earlier, we need to be doing it with everyone at the beginning, because then it's universal. I love that term, universalism, that somebody used earlier. That it would also give us a benchmark to be able to say, well, this is where we were. We're now here. What's changed? How can we help you? Because quite often, rightly, we're the last people to know. Oh, hold on, mum and dad are in different houses, different counties. You don't have the supplies that you need in that house to look after your child with diabetes. That's huge. But you didn't think to ask me for help because you were dealing with life. So I think at the beginning, potentially routinely if needs be, but currently we don't use anything. We might be piloting something in the near future.
Thank you. Any other questions from anybody? Amani?
Thanks. I'm just thinking, so we mentioned earlier we're going to redo the workforce audit this year. In the last workforce audit, I don't remember the data set entirely, but I think one of the questions was specifically, does the PDU have children, looked after children in their caseload? Yeah. So that, I think that was specific wording. Is there anything you would want to see, I'm not promising anything here, but is there anything you'd want to see in the upcoming workforce spotlight audit that didn't come up in the last one?
Yeah, absolutely. And I think Kaya would love to have those conversations, because
absolutely.
Yeah, we might need a residential. I think this is going to inform exactly the answer to that question. Personally, I feel from the personal experience, but also from my participants' experience, that the time, energy that it takes to do it, who is doing it in terms of who is working with those families, who is having, well, you're probably not going to go into that depth in terms of who's having those conversations, but actually, is there time in the job plans for some of these activities to take place? I have one participant who their centre has safeguarding worked into their job plan. That is the panacea. Social care, having those input, so many things. Amani, I could talk for 5 hours, and we're going to invite Kaya over. Yeah, definitely. If we could open that conversation, that would be amazing.
Nicola?
Oh, hi.
Hi, thank you very much for that. I think this is a great piece of work, so well done for starting it and really getting it out there in everyone's conscious that we need to be doing this. One of the issues that I think, Lynn, you have highlighted to our network beautifully, was a real issue, was about information that was hidden from the diabetes team or not shared with the diabetes team.
Yeah.
So, a child comes to a great deal of harm or dies, and it's only in the aftermath of that that everybody sits down and the police come into it and say about what they know about the family, and social care come in and say what they know about the family. But because it wasn't precisely about that child, it was about the environment around the child, that was never shared at a time that something could have been done about it.
Yeah.
So is there anything that you think we could or should be doing as a national group to try and break down those barriers of sharing information? Because that, for me, the parents sit there in a consultation room, and they can put on a really good show for 30 minutes and then walk out, and even though you ask the questions and you have these sort of concerns of this grading system, you have these concerns, you don't actually know the level of harm that child is being exposed to.
Yeah, no, I completely agree. And one of the benefits of some of this work locally that I hope to be able to perhaps roll out is opening those conversations with social care. And I know Lynn's subsequently had that experience as well, that actually the Wiltshire Children's Services are now engaging in a much better way. And I can only hope that through things like the AIM1 work, where we're actually working towards how can we work together more effectively with children's services so that they can understand our language and we can communicate in their language in a way that actually conveys the risk and our concerns and makes them think differently about neglect in diabetes as medical neglect. Interestingly, side topic, my thesis is currently being reviewed, and one of my supervisors came back with a curveball, which is actually, is this really neglect? Is it not physical abuse? So having some of those conversations to say, you're absolutely right, we need to be doing more, and how can we open those conversations and move it forward? I'm really excited to be part of this work stream at this point in time, because I think you're right, there's so much to it. That was a really political answer, I'm sorry, I didn't answer it.
Martha?
Very good, and I said we've all had these cases, haven't we? We really need to invite a social worker here, don't we?
There is at least one working with the Birmingham social care, with the children's team in diabetes, and I've had some work, there's some other faces around the room that I know. She's super keen and super engaged. And interestingly, what she said was, I held a knowledge exchange in the summer around sharing some of my information and trying to bring people together from children's services, which has led to some local developments, which has been great. But Isma came and she was saying that as a social worker within a diabetes team, she was received much better by the families than an external social worker from children's social care. I think that's huge, and that's exactly what we've seen with psychologists in the past, isn't it? So, I mean, the panacea is safeguarding in our job role, but also children's service type staff within our team. And I know some of my colleagues in the room, perhaps that have been around for a while, may have had that in the past. Certainly in Oxford, we've had social workers who joined our high HbA1c meetings, who are part of our teams to begin with, but things have moved and perhaps now they've been replaced by safeguarding teams. But actually, again, involving your safeguarding practitioners in the service is really useful. We've had 2 admissions in DKA this week, and one of the safeguarding nurses has been so helpful, having come to my knowledge exchange, in now driving forward those referrals. And is also feeding that back. So she's come back to us today with information about the fact that the ambulance staff have also put in a MASH referral for one of our kids. So including those teams as well, I suppose, Nicola, if you're not already, they can be that bridge sometimes. I don't know about if that's national, but our teams sit in MASH as well, so they get that information.
Thank you. Any final last questions from anybody?
Thank you very much.
Thank you very much, Diana. So we've kept beautifully to time. We've got 6 minutes spare. I'd like to say a massive thank you to all the audience at home for everybody who's managed to get here today. We've had some fabulous speakers. Thank you to all of the speakers. And a huge thank you to the NPDA team who work in collaboration with all of us, because they need the data but they work marvellously with us to produce some amazing outputs. And what we're able to do with reliable data is huge, and how limited would we be without it? So huge thank you from all of us to the NPDA team. Thank you.